our webinar. Just so you know that we are recording our webinar because we have lots of people who like to enjoy watching these at their own leisure. So if you're joining us live, this is great, welcome. And for those of you who are watching the recording, welcome as well. So my name is Dr. Samir Sinha. I'm a geriatrician, and I'm also the Director of Geriatrics at Sinai Health and the University Health Network, and I'm the Director of Health Policy Research at the National Institute on Aging. And we're really happy to have this webinar today to really have an opportunity to talk with a colleague of mine who's a frontline expert family physician, Dr. Vivien Brown. I'll introduce Dr. Brown in a moment, but we just wanted to welcome you both to our webinar called Reflecting on and Preparing for our 2022-2023 respiratory season. And we're really going to focus today's conversation about these common respiratory illnesses such as influenza, pneumonia, and COVID-19, which a lot of us are thinking about these days as we head into winter as well. So we just have a short presentation. I just want to really help give us some context. And then I'm going to introduce my colleague more formally, Dr. Vivien Brown. We're going to have, I've got some questions for her just off the bat that I want to ask her what she thinks, and we'll have a bit of a conversation. And then we're certainly going to invite everybody here to ask their own questions to both myself and Dr. Brown. Just in case you're new to our Zoom webinar formats, we have our Q&A function. So on the bottom of your screen, you're going to see the Q&A section. That's where you can pose questions that we'll be able to answer. If you have any technical questions, if you're having any connectivity or other issues, you can also communicate with our coordinator in the chat. And also the chat is your section if you just want to have some comments between each other or with our organizers as well. That's how we'll approach this, and we'll go from there. And as well, as we said, we're recording this so that this can be available for people to watch again, or for those who are going to be watching the recording to watch it for the first time that way. And we'll go from there. Perfect. So we'll go to the next slide. So we just want to note that we're very grateful for Sanofi Canada and for Pfizer Canada, who've provided an unrestricted educational grant for us to host sessions like these. We just want to note that the opinions that Dr. Brown and I and the NIA will be sharing are really kind of the slides and our views are really our views and our slides. These have not been prepared by these organizations. These two organizations do make vaccines and are interested in people getting vaccinated, but neither organization will guarantee the accuracy or the reliability of the information here. But we hope that that you will like the quality of the information that we're going to share with you. We'll go to the next slide. So I want to first of all talk about why are we focusing today's conversation really around COVID-19, influenza, and pneumonia? Because when we look at our top 10 causes of death, as of 2020, you can see that these are the three most vaccine-preventable causes of death that are now occurring in Canada. Influenza and pneumonia used to be the 7th leading cause of death in our country, and now it's been bumped to 8 because COVID-19 is now taken the third slot here. But the good news is these are all vaccine preventable diseases, and ones that we actually do have options that are available, and especially as we go into this cold and flu season, if you will, it's really an important time for us to think about where are we at with our vaccinations, and what can we do to best protect ourselves from these respiratory illnesses as well. We'll go to the next slide. So right now, when we think about COVID-19 in older Canadians, we know that older Canadians may present with COVID-19 symptoms differently and have less common symptoms. And this is also the same with things like influenza and pneumonia. Traditionally, we think about these three illnesses, if you will, as respiratory illnesses, and therefore that people are going to traditionally have just traditional symptoms such as coughing or sore throats and trouble breathing, for example. But often we know that people can present with many different symptoms. For example, someone might present with a fall, they might present with confusion, for example, and those might be more of the predominant symptoms as well. So it's always important to kind of be mindful that COVID-19, influenza, pneumonia can present differently in older adults, and older adults are more likely to have less common or what we call atypical symptoms. So to always just keep these things on the back of your mind, especially as we're going into, if you will, cold and flu season as well. So we know as well that when we think about how these illnesses have a predilection for older people, we know that when we look at Canadians who are 60 years and older, they currently have made up over 60% of our hospitalizations, and older Canadians still are the ones who are being most negatively impacted by COVID-19. In fact, 93% of our deaths to date have occurred amongst those who are 60 and older. So that's in COVID-19, but when you also look at the data around influenza and pneumonia, again, you'll see the vast majority of people who end up succumbing to those diseases tend to be older adults. We'll go to the next slide. So we know that when we start thinking about what makes older people at greater risk for diseases like COVID-19, influenza, pneumonia, we know that it often is the underlying the underlying issue of having chronic diseases or chronic health issues. And we know that 70% of Ontarians who are 65 and older, for example, have more than have one or more high-risk conditions that can put them at greater risk for influenza, but also pneumonia and COVID-19 conditions. We also know that with COVID-19, for example, but also with influenza, pneumonia, the older you are, the more likely you are to just have challenges related to your age, not because you happen to be older, but because as we age, our immune systems naturally weaken with time, and we're more likely to be living with more chronic conditions, and that's why we know that older adults are at greater risk. But it's the combination of age, representing a weaker immune system, and naturally more weakened immune system, and then the greater preponderance of high-risk health conditions, for example, that can then put our immune system at greater risk of succumbing to the negative impacts of one of these infectious diseases. We'll go to the next slide. So we know that when we have influenza, for example, it can cause severe health consequences, especially for those at risk of complications. So we know that when we look at those people who've been hospitalized, for example, with influenza in Ontario, 67% were ones who had an underlying health condition. And we often think about how these conditions, if you have an underlying condition, it's not so much influenza that you're worried about or pneumonia or COVID-19, it's sometimes how this can actually destabilize these conditions as well. And so we know that for those in Ontario who died from influenza complications, for example, 85% again had one of these underlying risk factors as well. So it's really important that not only our older people, but especially people who are older with chronic conditions, but also people who are younger and living with chronic conditions, that these are folks who really do think about the importance of getting vaccinated, when they're eligible as well. We'll go to the next slide. So why are we really worried this year about flu season? Many people say, you know what, we were told about this potential twindemic, a year ago, and it really didn't kind of pan out, for example. So was that just fear mongering, or was there a real concern here? And really what we do know is we take our best evidence or advice from what we're seeing in places like Australia and New Zealand, where they have their flu season 6 months earlier than we do because of, again, the reversal of seasons that occur. This is a chart basically showing the last 5 influenza seasons that have occurred in Australia. And what you can see, for example, is that when you look back to 2020 and 2021, that's the green dashed line or the light blue dashed line, you can't even see them. They don't register. In fact, if you look very closely to the left, for example, you can see the green dash is starting and then kind of disappearing by week 13, if you will, because that's when, again, we started doing things like universal masking, for example, and started to have more physical distancing measures being put in place in 2020 when we were really trying to protect ourselves against COVID-19. And that basically helped to kind of dampen and not allow the 2020 flu season to get underway. In 2021, we were still, if you think about a year ago, we were still taking many of these precautions to protect ourselves against COVID-19, usually masking and physical distancing and other measures, for example, and that those extra public health measures we were doing were probably responsible for why we didn't really see much of a 2021 flu season in places like Australia, but also places like Canada as well. But what we have seen is that we know that every year that we don't actually have a flu season, we have a growing percentage of the population that's not exposed to flu and could have more weakened defenses. And that's why there's been a lot of worry against people who study kind of flu overall, to realize that that we were in store for probably a significant wave. And so what you can actually see here is that the thick red line that you see is really what the last flu season or the latest flu season in Australia and a similar graph from New Zealand have shown, was basically that we had a much more significant early and big flu season there, and bigger than anything that we've seen before in the last 5 years, compared to, say, 2017 and 2019, which were particularly bad flu seasons. And this is well above the 5-year average as well. So this is why a lot of public health officials and hospital folks are really worried right now about what could be ahead of us, and why there's a real interest in really recommending that everybody 6 months and older get an influenza vaccination as soon as possible, for example. So we're trying to hope that we're not going to see what we saw in Australia, but right now the indications are generally what happens in Australia happens here. It's just a matter of months. That's why there's a lot of increased interest in making sure that this season in particular, you get vaccinated if you can. We'll go to the next slide. So right now, we know that when we think about pneumonia, for example, it's been associated with many chronic heart conditions, respiratory conditions, cognitive impairment, and diabetes. So again, if one is living with one of these chronic conditions, we know that these are some of those classic things that of why we recommend people to get vaccinated against influenza, pneumococcal disease, and also COVID-19. Again, all of these things, for a variety of reasons, kind of put our bodies at increased risk for complications, but also for even acquiring these illnesses in the first place. We'll go to the next slide. And we know that pneumonia is associated with one of the top 10 reasons why older adults are visiting our emergency departments in Canada. So we know that there were 23,000 pneumonia-related emergency department visits last year, according to the Canadian Institutes for Health Information. So while we, again, didn't see much of an influenza season last year, for example, we still had a lot of people coming to our emergency departments, for example, with pneumonia, and we knew that a lot of it was actually preventable had people gotten their pneumonia vaccinations as well. So again, why we're always trying to make sure that people stay up to date with their recommended vaccinations, and you'll hear a little bit more about why pneumonia remains such a challenge in our society in particular. We'll go to the next slide. So right now, what are the recommended vaccines for Canadians aged 65 years and older? Right now, we, unlike, say, Australia or the United Kingdom, for example, we don't actually have one national kind of vaccine strategy, if you will, overall. So what you'll find is unless it's COVID-19, where we're using the same vaccinations that are available in every province and territory, for example, with influenza and pneumonia, there are different types of vaccines that might be made available, and that may be covered in different ways in particular. So that sometimes makes it a bit more confusing as to what's covered and where is it available and who can give me my vaccine, for example. But to simplify it, through the NIA, we've just kind of put together this simple diagram here, just reminding us about these three specific diseases that really, what are the current recommendations when we look at it? Right now, we recommend that for COVID-19, if people have not yet had their primary series, and we know the vast majority of older adults, over 90% have, that people are recommended to get their primary series. And then we hear about the primary series being, either one dose of the Johnson & Johnson, for example, or usually it's a 2-dose series, for example. But usually it's recommended that right now, if you're to start, you're using the mRNA vaccinations for your primary series, and then using a bivalent mRNA booster, for example. People sometimes are asking, can I just start with a mRNA booster, for example, for my primary series? That's not how things are being recommended, for example. So again, it's really about focusing on the mRNA vaccinations. But the good news is, if you're looking for other choices, for example, we have up to 8 different types of COVID-19 vaccines that are approved. And so there are lots of different options available, but this is the current recommendation. Right now, it's recommended that every fall that people are getting an annual dose of the influenza vaccination. Depending on where you live in Canada, for example, there are different kind of types of influenza vaccine being made available. So generally, there are standard doses available for anybody 6 months and older, but we know that for older adults, there are multiple stronger versions available for older people. So some provinces, for example, are offering what they call the high dose vaccine, and others are offering both the high dose and what we call an adjuvant vaccine, but collectively we're just calling them enhanced vaccines. The idea that, remember, that there are better and enhanced alternatives for older people. But again, as I'm sure Dr. Brown and I will discuss, just getting anything is better than getting nothing. And we still don't have enough people just getting something. When it comes to pneumococcal disease, it's recommended that people get at least 1 dose of the PPV-23. That's available free of charge in every province in Canada, for example. But people can also consider getting the PCV-13 if they want more enhanced protection as well. So again, these are the vaccines that are available. And again, no matter where you live in Canada, there are enhanced influenza vaccinations that are available. Both options of the pneumococcal vaccination are available, and all of the COVID-19 vaccines are available. And so this is kind of what's being recommended for people who are older people to consider. We'll go to the next slide. So right now, we know that part of our national vaccination coverage goals is to have at least 80% of older adults get the pneumococcal and the influenza vaccines. This is what our Public Health Agency of Canada has put as its goal for over a decade now, but we've never actually reached these levels. So remember I talked about how there were 23,000 ED visits for pneumonia alone last year. Part of the problem is that only 55% of older adults have received the pneumococcal vaccine, when you only need to get at least a minimum of 1 dose when you're 65 and older. So we still have a huge number of older people, about 45%, who have not received at least 1 dose of the pneumococcal vaccine in that age group of 65 and older. Somehow we've done a really good job in children under 2 who are also at risk of pneumonia-based diseases, and where over 90% of children under 2 have been vaccinated. Yet when we talk about our older population, only 55% have received the pneumococcal vaccine. Right now, only 70% of Canadians who are 65 and older have received the influenza vaccine during the 2020-21 season. So again, 10% lower than what the target goal for PHAC is. And we still see this kind of level of hesitancy, yet we didn't see that same level of hesitancy when it came to getting the COVID-19 vaccine. What we do know is that the vast majority, over 90% of our older population, has received their primary series, and at least 81 or 82% of Canadians now, older Canadians, have received an additional booster dose against COVID-19. So we're doing much better on that than we are on pneumonia and influenza, and we can certainly do better. Go to the next slide. And so, as I mentioned, right, we've done really well in getting Canadians vaccinated against COVID-19. And so we know that our vaccine rollout for COVID-19 shows that when barriers to vaccination are addressed, including availability, accessibility, and cost, vaccine uptake increases amongst older adults. So we'll unpack a little bit more about what do we mean by, why are we seeing lower rates with Dr. Brown. And we'll talk a little bit more about what we can do to break down some of these barriers to getting people vaccinated. We'll go to the next slide. And right now, we know that when it comes to thinking about influenza vaccination during the pandemic, the NIA conducted a recent study, for example, and we found that 24% of adult Canadians report that the pandemic has made them more interested in getting the flu shot this fall. We know that 59% of adult Canadians have reported that they would get a COVID-19 booster and the flu vaccine at the same time if it were offered. And the good news is that the majority of adults and older adults are aware that there actually are enhanced alternatives to the standard influenza doses. And people have said that if it was offered to them, they would be more likely to get it as well. So that's good news that people are aware and that people are interested in getting these enhanced vaccines. We'll go to the next slide. And so right now, we know that if you are looking for getting one of these enhanced vaccines, they are available for free in these provinces across the country as well. And so again, many of you are always watching from across Canada and even beyond. So just to remember that these are options that are available in many provinces across Canada. And so again, if you are interested in getting something better than the standard dose, then these are options that are available for you as well. We'll go to the next slide. And right now, again, well, the good news is that you can co-administer vaccines as well. We'll talk a little bit more about this, but you are able to take your COVID-19, your influenza, and your pneumococcal vaccines together. And so again, you can ask your healthcare provider what vaccines you're eligible for and which could be safely co-administered to make it more convenient for you to stay up to date with your recommended vaccines. So it is possible, and we'll talk a little bit more about that in a moment. Go to the next slide. So with that, we will just say thank you for watching that, just kind of that introductory. I want to level set a little bit. And now I want to introduce my colleague, Dr. Brown. She has an impressive bio, and I'm going to read it out because I want you to know why we've asked Dr. Brown to join us for this conversation today. Dr. Brown is a family physician and an author. She's based here in Toronto. She's been educated at McGill University, and she's currently appointed to the Department of Family and Community Medicine at the University of Toronto, holding the rank of assistant professor. She's an award winner for teaching on many levels. Her major interests are in the area of health promotion and prevention for women and continuing medical education, adult immunization, and vaccine-preventable illnesses as well. In 2009, she won the prestigious Enid Johnson MacLeod Award from the Federation of Medical Women of Canada for teaching in women's health. And more recently, the College of Family Physicians of Ontario named Dr. Brown Physician of the Year for the region of Toronto, and that was awarded in November 2012. She is also the past president of the Federation of Medical Women of Canada and is the current vice president for North America for the Medical Women's International Association. She's lectured locally, nationally, and internationally on preventative medicine and implementation issues around vaccination, sharing her passion and Canada's experience. In March 2017, she was honored to present HPV initiatives in Canada at the UN meetings for the Commission on the Status of Women. And in 2018, she was honored with the Media Award from the North America Menopause Society for her work in women's health. So she's also received the May Cohen Award from the Federation of Medical Women of Canada for her work in women's health. So her book, The New Women's Guide for Healthy Aging, and updated release of her previous bestseller has just been released as well. So now you know why we wanted to get Dr. Brown to join us. Not only is she very distinguished, but she is a true frontline family doctor. I know when we were just briefly chatting, she was mentioning to me that she's got her weekend filled with vaccine appointments and clinics that she's now running as we're heading into flu season. So we were glad that we could snag her for this hour, so we could just get some opinions together. So we're on first name basis, and this is our Q&A piece. So we're going to stop being formal with each other. Vivien's going to call me Samir. I'm going to call her Vivien, and we'll just get underway. But I just wanted to say, Vivien, any opening thoughts? You heard kind of a little bit of our analysis from the from the NIA, the things we've been looking at. I know our colleagues have shared some of the reports that we've been putting out that kind of give some of the evidence and the information behind this. But just any opening thoughts, and then I've got some more specific questions for you, and then we're going to get to our audience questions as well.
Well, thank you, Samir, for having me here. It's really a pleasure to work with you. And I think sometimes we're victims of our own success. Last year in influenza season, we were all still masking. We weren't doing very many indoor events. People were up to date with their COVID shots. We were very careful. And so we didn't see a bad influenza season last fall. And so a lot of people are saying, is it really that bad? Like, do I really have to bother? And I think your comment about Australia is just really important. Australia is about 6 months ahead of us. And they saw a pretty active influenza season as our social distancing and using of masks and hand washing has decreased significantly. So I think the most important thing that I'm going to say in the next 30 minutes really is that it's not just the flu. It's an influenza infection, and it can really affect your long-term health, your short-term health. It can destabilize whatever chronic disease you're managing with. And you really put your independent living at risk when you end up with one of these significant lung diseases, influenza, pneumonia, and COVID.
And you mentioned that, Vivien, is that I think a lot of people just think, well, it's just a cold, for example, or people say, well, I'm so up to date with my boosters now against COVID-19 that it's just mild, and it's just a mild respiratory illness, and that's all it is, for example. But you mentioned something there, and something that I was highlighting in some of the slides here, is that if you have an underlying chronic condition, that puts you at greater risk for those negative outcomes. But you also talked a little bit about this can destabilize. So with your patients who have diabetes or who have heart conditions and that, why is it more important for you to get them vaccinated in particular, especially if they're older?
Yeah. So, someone may be living in the community, doing very well. They're on medication for diabetes, but it's under control. They've got high blood pressure. Maybe they've got high lipids. Maybe they had, a mild heart attack 10 years ago. Their heart disease is under control, and they're doing fine. Then they get an inflammatory lung disease, whether it's influenza, whether it's pneumonia, whether it's COVID. And we know that their risk of a heart attack in the first 4 weeks after an inflammatory lung disease skyrockets. We know that diabetes quickly is out of control. If they have COPD or asthma or other lung diseases, that becomes difficult. And all of a sudden, they've gone from this independent person living and working in the community and doing fine with some chronic disease that's being managed. All of a sudden, they become a patient. They become an inpatient in hospital. If they get discharged from hospital, there's a high level of readmission at 30 days. So we see when people are over 65 and they get a bad lung disease, they may survive it. They may get discharged home, but they end up back in hospital a month or two later. And we know that the death rate, mortality rates really are much higher if you're over 65 with one of these diseases. So I think we have to not just think about this as lung disease or lung infection. I think we have to think of it as a systemic infection. It's affecting your whole body. It's affecting all the other organ systems. And some of your organ systems, if you're 65, 75, 85, you're not 25. They're not working as well as they did when you were much younger. And so we start to see kidney disease and we start to see other diseases impacted by inflammatory lung disease.
Excellent. And I think that's the thing, we see lots of people getting admitted, to my hospitals, especially over the, over this fall winter season. And again, it started off as something like influenza or pneumonia, but then the reason they're here and the reason they get hospitalized is, as you said, it triggers a heart attack or it destabilizes another illness. And one of the things, as you just said, it's not only that your organ systems get affected and these other issues get triggered. But the biggest thing that I see, especially as a geriatrician, is how this can wipe people's function and really negatively affect them. So that, for example, someone, your pneumonia is cured, for example, we've treated your pneumonia, for example, but now you can't walk as you're able to. We can discharge you home, but you now need a lot more help with bathing or dressing. And we know that 50% of people who've been discharged with worse than baseline functioning, and that's at least 1/3 of older adults who get hospitalized, they don't recover the function they lost, 6 months later. So we know that this is a real issue. It's, as you said, it's not so much kind of the influenza or the pneumonia, it's all those negative consequences that, as you said, can destabilize illnesses, trigger things like heart attacks and strokes and other issues, that whole body systemic disease, but then also can really negatively impact your function. I'm sure you've seen that in your practice as well.
I have, and Samir, there's a really excellent respirologist in Ontario, and he says when you get a serious pneumonia, you are never the same. And what that means is your level of function, your breathing, your independence, your walking, your being able to do your activities of daily living, everything gets impaired. You still may be discharged home. You may not end up in a long-term care facility, but you're not as independent, energetic, and you're not as able as you were before. You're partly disabled.
So I ask you this question because right now, I feel like there's still a disconnect, because when you saw some of those stats about, again, the Public Health Agency of Canada says this is such an important public health issue. We want at least 80% of older Canadians every year to get vaccinated against influenza. We want to make sure that 80% of older Canadians have been vaccinated against pneumococcal disease. But you see that, wow, if you make it to 65, you have at least 20 more years of life expectancy ahead of you. But this population is only 55% vaccinated against pneumonia. What's driving this? People use the term hesitancy. We didn't see this hesitancy around COVID-19, but what do you think is driving? Like, why are we just not getting those levels of interest against these other vaccinations that are available and free? What do you see on the front lines? What do you see in your practice?
So I think there's a big difference between someone who is refusing vaccine and someone who is vaccine hesitant or perhaps has vaccine fatigue. They're just tired of all this. And I'm tired of all this too, but that doesn't matter. We need to think about our vaccine preventable diseases. So someone that refuses vaccine, absolutely, I'm not going to argue with. There's no point, and that's a very small number of Canadians where they just don't believe in it. Most people accept vaccine, but there's a number of people that are vaccine hesitant. And the research shows that when we educate people who are vaccine hesitant, they're much more likely to take vaccine. So maybe someone is just worn out about the discussions. Maybe they haven't seen their doctor in person in the last year or two. All the calls have been virtual or on the Ontario Secure Network, and they just haven't been there in person. When I actually see someone in person, and I do that every day, I'm really looking at what I can prevent. I'm treating blood pressure to prevent a heart attack. I'm doing a mammogram to try and pick up breast cancer early. I'm doing Pap tests to try and pick up cervical cancer early. But I can actually prevent disease, not just pick it up early, by doing immunization. So I categorize these as vaccine preventable diseases. And the bottom line is I don't want you to die of one of those diseases on my watch. If there's something that I can do to prevent it, I am going to do that. You know, when we look at pneumonia, for example, 40% of people in hospital with pneumonia had a preceding episode of influenza. So it's not just a flu shot. It's an influenza vaccine to keep you healthy, to keep you from getting pneumonia, to keep you from getting in the hospital. And so I think we have to be very clear about what we're doing. We're not eliminating risk. There's no vaccine that's 100%. And we certainly have learned that with COVID, but we decrease severity. We decrease the impact on your system. We decrease the death rate. We decrease the hospitalizations. And those are huge advantages, especially as someone's immune system is getting a little bit weaker because they're getting a little bit older, and that happens to all of us.
So the World Health Organization, they often talk about kind of, as you said, it's not so much vaccine refusal, but it's more that, you know, that people are just not, are not necessarily, you know, kind of, you know, put in that position, you know, where they're ready to kind of get vaccinated. And they talk about these 3 C's. They talk about costs, convenience, and complacency. And the good news is I think that for, you know, across Canada, we're lucky, you know, that the cost isn't a barrier, that, as we said, that these vaccines that we're talking about today are all generally free and universally available. Now, there's some provinces where what's available might differ, for example, but the key is that these vaccines are generally available. So that's good, you know, so we've kind of eliminated that barrier. But we get to these 2 other areas of convenience and complacency. And so I wanted to start with this first one, because I think, again, right, you know, you're convincing me that, you know, okay, these are the things I want. These are immunizations. These are, you know, these are vaccinations to prevent, you know, kind of serious disease. But we still see a lot of people. You must see people who still say, it's just the flu, it was minor, it was just a cold, for example, or pneumonia. I had pneumonia and it was fine, for example. But often I think that a lot of people still don't appreciate or are able to differentiate what a common cold is and how that's not necessarily influenza, for example. And as you mentioned, you know, influenza, one of the biggest challenges of influenza is that it can make you more prone to developing a pneumonia, which then again has that other consequence. So can you talk a little bit about that complacency and how do you combat that? How do you, you know, if someone says to you, yeah, like I had the flu last year, it was just a little cough, that's all I had. How do you battle that kind of complacency or help people explain to people why they should consider getting vaccinated?
Well, one of the things that I think we all need to understand is that we have a responsibility to our loved ones, to our family, to our community. And these are very infectious diseases. There's a high transmission rate. When you get immunized, you not only protect yourself, but you most likely are decreasing transmission. So when you get together with everybody over the holidays, or when you see, you know, your niece who just had a baby and you know, babies can't be immunized. We don't immunize before 6 months for influenza. Essentially, you are putting others at risk if you have not been immunized. And so am I making people feel guilty? Maybe, and I'll accept that. But what I want them to understand is that this is all about keeping our community healthy as well as the individual. And so when someone says, I had the flu and it was no big deal, I'll say, are you going to be around your grandparents in the next couple of weeks, the next couple of months? Do you want to be the person who brings home influenza and then gives it to somebody who gets severely ill? What about pregnant women? What about people who are immunosuppressed on various drugs or with various diseases? You know, part of treating everybody, and I'm grateful that Ontario offers influenza vaccine to everybody, is to keep the community healthy, to keep the kids in school, to keep the teachers in school. So it's not just about treating for your own self-interest, although admittedly that is important. It's also the herd effect. It's trying to protect those that either can't be immunized for some reason or would get much sicker if they get the disease. So it's decreasing transmission. And I think people understand that. People understood some of the issues around transmission with COVID and understood the need to have social distancing. And that when we're all together, which we probably will be in December around the holidays, everybody together around a dining room table, if one person is sick, that's going to spread to the whole family.
Well said. And then, like, last question I have for you is, again, this convenience aspect. So co-administration, right? Is it possible? Is it possible do you have people who get all three, shots at once, or how do you, why is it important, for us to be able to make multiple vaccines available at the same time?
So as you mentioned, somewhere in the beginning of the slide presentation, we have national guidelines. Those national guidelines are from the National Advisory Committee on Immunization. And they came out with a good research and a good review and said it is safe to co-administer. What that means is you can take the influenza vaccine, a pneumonia vaccine, and even the COVID vaccine all at the same time. Well, that means if you're going to a pharmacy or you're going to your doctor, you can get your immunizations up to date. And so we want to make it as easy for people as possible. And so if you're in for your flu shot, let me give you your pneumonia shot at the same time. Pharmacists have done a fantastic job. We've learned the value of collaborating with pharmacists in terms of immunization. The ability to get immunized is usually available on the weekend and later at night. It's very convenient. But the bottom line is you don't have to go back 3 times. You can go and get immunized, and you can have multiple vaccines at the same time. And we know that it's safe to do it. There may be increased reactogenicity, which means a sore arm for a longer time, or even fatigue, sometimes a low-grade fever, but it's not dangerous. It all gets better by itself. And for people that may not live in a big city and may have to drive a distance to get somewhere, going once and getting it all done is much more convenient than having to go back again and again.
I think it's really helpful to hear that too. And again, it's great, as you said, that NACI has confirmed, for example, that co-administration is safe, because again, we found the majority of older Canadians in that recent study who said, oh, wow, if I can get both, if I can get them both at the same time, I'd be happy to do that. Because again, I think some of my older patients, and probably some of your patients too, having to ask, someone to take off some time from work, to maybe take you to a vaccine clinic or to a pharmacy or their primary care providers, doing 2 trips or 3 trips when you could do it all in 1 trip, for example, much more convenient for everybody. But I think sometimes, people have heard, and especially at the beginning of the pandemic, that it may be best to wait a certain period before you get that. But I think it's important that now that NACI has told us that you no longer have to wait, between these. You can actually take these things safely together. But again, as you said, best to check with your primary care provider first to say, hey, what am I up to date on, and what am I due for as well?
And Samir, NACI at the beginning, when we were giving COVID shots, said, yes, wait 4 weeks after any other vaccine, wait 2 weeks after you get COVID vaccine. And that was out of an abundance of caution. We weren't sure how people were going to react. We wanted to be sure that there was a good enough data on a single vaccine so we would pick up anything unusual. What's very reassuring is in 2 years, we haven't picked up anything unusual. And we've now said we don't have to be that cautious. We can safely co-administer. So it's not just me telling my patients, it's all of Canada's guidelines saying it's safe to co-administer.
Perfect. And then last question, right now, I'm sure, you're getting calls like I'm getting calls saying, which brand or kind of what do I do? There's 2 types of bivalent vaccines. There's different types of enhanced vaccines out there, for example. What is your message when people ask you kind of which ones, what should I do, and how to do that, for example? Because I tend to say, getting vaccinated is better than no vaccination whatsoever, for example. And often there really isn't that much difference, for example, between the different things being offered. But how do you help walk people through when they ask you kind of, what's available for me and what should I do?
So generally speaking, the differences between the various vaccines are subtle and not earth-shattering. I think there is a difference between conjugated vaccines and polysaccharide vaccines. So with the pneumonia vaccines, for example, I think it's worth it for people to pay for a conjugated vaccine, which is not covered for the average person in Ontario. The conjugated vaccines in general give longer immunity. When we're looking at the influenza vaccines, our guideline is from 2018, so it's a little bit out of date. But we do know that the enhanced vaccines, and in particular the high dose vaccine, is giving older people more antigen and they get a better response. And what we've seen in some US data is about a 23% reduction in hospitalization from influenza. So I think it's important to talk to your primary care provider about which vaccine is best for you. But the bottom line is any of the influenza vaccines are better than no vaccine. And so if something is in short supply, or if you're in a facility that doesn't have options, getting something is much better than getting nothing. In terms of the COVID vaccines, you know, when we're looking at these mRNA vaccines, it's like excellent and more excellent. These are phenomenal vaccines. And I think that people should be more than reassured. I think we should be excited about the fact that we have vaccines of this caliber. And, you know, some people said, well, how did they come up with this so fast? I don't trust it. And the reality is they were working on the mRNA platform for the last 10 years. The platform has been under development for a long time. The transition to have a vaccine related to the mRNA platform is what came out relatively quickly when COVID happened. And so I tell patients, it's like holding your cell phone. Your cell phone is the hardware. That's the mRNA platform that took 10 years to develop. The app is what we just downloaded. That's a bivalent vaccine. And mRNA platforms are now being looked at for specific cancer drugs and other kinds of issues. So when you have that cell phone, whatever app you downloaded, whichever vaccine you're getting, they're all pretty fantastic. And I think people should be reassured that it's not brand new technology. It's taken a lot of years. And I think we are really quite privileged in Canada that we have the option to get vaccinated. So I don't have a problem if someone goes for Moderna or Pfizer. You know, I think there are slight differences, but they're relatively subtle and they're not clinically significant. It's not like one vaccine has done so much better than the other.
And so I think it's important, as you just said, I think it's important to make sure that check with your primary care provider, your local pharmacy, where it's the convenient place for you to get vaccinated, to figure out, you know, what are you eligible for, what is available. In some places, certain things might not be in supply or they might not have, but I wouldn't kind of then say, well, I'm going to wait around for this brand or that. I think, again, as you said, there usually is something available, and it's better to get something rather than nothing at all, basically.
That's how I feel, absolutely.
Perfect. So we're going to go right into questions now. We have a number that have popped up here, so I'm just going to go through them, and then I'm going to pitch some directly to you, Vivien, as well. But there's some that are kind of that I'll pick off as well as we go through. So the first question from Valerie is, what number is COVID-19 in 2022 in relation to causes of death? And so we showed you the data from 2020. What we can say is, while it hasn't been officially released, that COVID-19 remains still the third number cause of death, just due to the sheer number of people dying from heart disease and cancer still. But we're talking about close to, sadly, we're getting closer each day to about 50,000 people who died since the pandemic began, specifically from COVID-19.
And Samir, just to add to that, we're getting about 200 deaths a week in Canada. So we're, you know, COVID is not gone. It's important to get vaccinated, and 200 people is a significant number. And that's the current number, I think, as of early September, was still about 200 a week.
That's it. Marguerite asked this question. I think, Vivien, you helped to kind of answer a little bit about this, but again, it's about the bivalent boosters. And it says, are those folks who had the bivalent Moderna booster recently at a disadvantage compared to those who waited for the Pfizer booster? Do they need to wait 6 months to get better protection against recent Omicron variant protection coverage? I'm sure you may have had some patients, for example, who are saying, should I have buyer's remorse, if you will?
Yeah, it's a great question. And what you need to understand is that both the vaccines fight against the spike protein. And the spike protein in BA1, which is what's in the Moderna vaccine, is slightly different than the BA4-5, which is what's in the Pfizer vaccine. I'm told that there's new variants coming already because the UK is ahead of us and they're already seeing something that they're calling BA7. The bottom line is these spike proteins look very similar. And so in the data, there's great cross-reactivity. So the BA1 in the Moderna vaccine has high efficacy against BA.4/5. The differences between the two vaccines in terms of efficacy was about 90.3 in the Moderna and about 91 in the Pfizer. So you're looking at a 0.7% difference. So full disclosure, I took the Moderna and I have no problem with that. And I know that I've got cross-reactivity against the BA.4/5. So there's nothing to do. You're good for about 6 months, and we'll know in the next 6 months whether or not we're going to need another vaccine or whether this bivalent vaccine has a longer clinical lifetime and whether we need something next fall.
Here's another question kind of related to our COVID vaccines. I believe the recommended wait time is 3 months from the onset of a COVID infection to get the 5th COVID vaccine. Is this a fixed timeline? What about having underlying conditions such as diabetes?
It's 3 to 6 months, so it's not 3 months as a hardcore number. And the reason for that is because if you just had COVID, you mounted an immune response, you fought it off. So you're not going to get as much benefit from the vaccine. So there's no rush to get vaccinated before 3 months because you've already mounted a good clinical response by fighting off COVID. If someone is immunosuppressed or very frail, I would get the vaccine somewhere between 3 and 6 months. For the average person who just had an episode of COVID, you can wait 6 months. You've got good antibodies because you've just fought off the disease.
So one of our colleagues, Dr. Canine Stark, says, Quebec doesn't have enhanced anything, exclamation mark. They said, I live in Quebec. What can I do? Almost 80 plus years and COPD, right? So again, this is that aspect that people say, I don't have enhanced anything, so I guess I don't get anything.
That's fine. That's fine. Take a regular influenza vaccine. Take a conjugated pneumonia vaccine. You have COPD, you're over 80. A conjugated vaccine is going to give you better immunity than the polysaccharide vaccine, which is the one that's offered for free. Wash your hands. When you're out in public, wear a mask and try and keep your social distance from people this winter so that you're not exposed to others coughing and sneezing. So you're not stressing your immune system. Yes, the enhanced vaccines may get a better response, but the standard dose vaccine is still very valuable at every age.
And our next question is, one of the barriers to promoting the flu vaccine is there's no published level of efficacy as there was for COVID vaccines. So what's the expected efficacy of this year's flu shot?
So what we need to understand is that influenza virus changes every year. It mutates. And when we make vaccine, we're trying to match some of the mutations. In general, taking the vaccine decreases the morbidity, which is how sick you get, decreases the mortality, whether or not you're going to die, and decreases the severity of the infection. It doesn't eradicate the virus. And so we're not expecting influenza to disappear, but we're expecting decreased hospitalization, decreased illness, and more mild illness. And we think that this year is a relatively good match. And we know that from the Australian data, right? They're about 6 months ahead of us. So in general, I can't give you a number, but what I would say is that this is a vaccine that's going to, in general, keep you from getting very ill and keep you out of hospital. And if you get the flu for a day or two at home, okay, watch Netflix and you'll be fine. If you get influenza and you end up in hospital and in the ICU and on a ventilator, even if you survive, you're not going to be fine.
Perfect. Angus asks, are the COVID stats that you quote on the numbers of people who have received their 2 doses still relevant, given the relatively short length of time that the immunization lasts? You know, I think overall, I think the key is these stats still matter, for example, because we know that Canadians who've received their primary series and at least a booster, that while, for example, your antibodies, might diminish with time, we still know that you still have a really good level of protection within you against severe illness. So there are different things that we measure when we think about immunity. But I don't know, Vivien, if you have anything else to say about why it still matters, for those folks who even got that primary series a while back.
Well, it's all about hospitalization rates. We've seen decreased hospitalization rates. Most people that have done very poorly were not immunized. And so, yes, I think it's important to get boosted. I think it's important at some point we may need to repeat the primary series, get the vaccine. But the bottom line is, because in Canada we did really well overall, we've seen, compared to other countries, decreased hospitalizations and decreased death rates. That doesn't mean we can sit back and sort of rest on our laurels, because we need to keep that up. And that's why I think getting the bivalent shot is so important, because what we see is it boosts your immunity to the original Wuhan type of COVID, as well as the more current types. And this is a clever virus. It keeps on changing. And we want to boost the immunity that we've already got now at a low level, because we were immunized more than a year ago.
We had David from British Columbia, who notes, for example, that again, not every kind of enhanced or preferred, vaccine is actually free and covered, for example. And so always kind of just emphasizing the importance of asking your provider, what is available for me, and appreciating sometimes things might not be covered, but your provider probably can help determine with you what's actually, what might be right for you and what might make sense, for example.
Yeah.
We have a few questions around co-administration. So we have a colleague who's asked 3 questions. So I'll walk us through, but I think they're all kind of along the same side. So Gihane is asking, are there any studies about taking multiple vaccines at once? And are there any side effects, especially for someone with a weak immune system? They've noted that they felt very sick after having their last COVID-19 booster, so they're just worried about taking multiple vaccines at once. Because they say, how would you know which vaccine gave you a reaction, for example, if you're going to suffer side effects? So I think they're just nervous about saying, what would,
Sure.
So if this is your patient, Vivien, what would you say to them?
Sure. So if you're really nervous about it, just go take the COVID vaccine by itself. Give yourself a week, and then you can take the pneumonia and influenza vaccines together. There's no harm in separating them, but let's just remember, when we see infants, we give them 5, 6 different vaccines all at the same time. We give them measles, mumps, and rubella. We give them a pneumonia vaccine. We give them tetanus and diphtheria and H influenza all at the same time. And they're perfectly fine. They often have some irritability and a low-grade fever, but we know it's safe to do it. So it's safe to co-administer, but if you're not feeling comfortable about that, then you can take them one at a time, and I'd wait a week between each shot. What you'll see if you're going to get a reaction with the COVID vaccine is within about 48 hours, you do feel fatigue, sometimes a low-grade fever. With the influenza vaccine, most people get very few reactions. And with the pneumonia shot, you get a sore arm.
Absolutely. Someone was asking, if we had COVID, how long do we wait to get to the bivalent? I think you already answered that.
3 to 6 months.
Yeah, exactly. 3 to 6 months, is how long we recommend, depending on your level of risk, for example. We've had a few questions around the pneumonia vaccines and kind of saying, what's the ordering if you get one or the other, for example? So I know, and Vivien, I'm going to get you to correct me because I know you eat and breathe this every day in your practice. Basically, if you've had the PPV-23, which is kind of the standard, universally covered vaccine, for example, then after that, you can follow up with a conjugated vaccine as well. If you start with the conjugated vaccine, because you can absolutely start the other way around, I understand that they recommend that you do eventually get your PPV-23 as well, but there's just kind of that approach. But did I get that correct, Vivien?
So yes and no. Okay. If you do it's always conjugate before polysaccharide if you've got your options. And the conjugate vaccine is PCV13, but now in Canada, we also have PCV15 and PCV20. We don't yet have NACI guidelines on those 2 vaccines, but the Americans do have guidelines. And the Americans are saying that if you take PCV20, which has 20 serotypes that are covered in the vaccine, that's it. You don't need PPSV23. If you're going to take a lower level of a conjugate vaccine like PCV13, then you'd wait 1 year before you take the No, sorry, you wait 8 weeks before you take the Pneumovax or the polysaccharide. If you've done it the other way around and you've just had the polysaccharide, you wait 1 year before the conjugate. So conjugate first, 8 weeks, polysaccharide. If you've taken polysaccharide first, 1 year before you take the conjugate. And if you're taking one of the newer conjugates that has a much higher level of serotypes, you may not need the polysaccharide vaccine. But I would say stay tuned on that. We don't have our Canadian guidelines yet. The vaccines are approved in Canada, but we don't have our guidelines. So that's the American guidelines. And that's my personal opinion. There's no Canadian guidelines yet.
Perfect. We have 1 minute left, and so and we have more questions that are pouring in. But I appreciate everybody's time and a real robust group of individuals to chat with us today around kind of our fall season respiratory vaccinations that are currently available. I want to thank Dr. Brown again for her time today. It's always great to hear from a colleague on the front lines and just really get that expert advice and to dialogue together as colleagues and friends. We will be making this webinar available so you can watch it again. And we also will be releasing within the next week or two a pamphlet that helps to summarize in easy to use kind of language so that you understand your options and these things more clearly, including why each of these vaccinations, including tetanus, is actually important and something that you can take to your doctor like Dr. Brown so that you can have further conversations about appreciating what's right for you. So look out for that. Everybody who's watched this or registered for this, I know we had about 400 people do so, will receive that, and that'll be available for you to share with your friends and families. Dr. Brown, thank you again for your time.
Thank you.
And have a great day.
Thank you for the work you do. It's really a pleasure. Bye now.